Noswaith dda, a croeso, good evening and welcome. Thank you for joining us this evening. My name's Professor Steve Riley. I'm the Pro Vice Chancellor for the College of Biomedical and Life Sciences here at Cardiff University. You're here this evening as part of the Cardiff community, including alumni, staff, donors and friends who are supporting the university. Tonight's event will be recorded and you'll receive the link afterwards, which you are welcome to share as you see fit. I'm delighted this evening that we are showcasing our excellent research and the exciting talent that are our research colleagues. This evening, we will hear about research happening within the Wolfson Centre for Young Persons' Mental Health. This was established in 2020. The Wolfson Centre is working to better understand adolescent mental health with its experts in development and clinical psychiatry, genetics, social science, and neuroscience. Better understanding can inform new and effective ways to offer practical help to people affected by these conditions. We will hear this evening about attention deficit hyperactivity disorder, ADHD, a condition that affects people's behaviour. Most people are diagnosed with the condition before the age of 12, but many are adults before receiving a diagnosis. And as the title of tonight's talk makes clear, girls are less likely to receive a diagnosis than boys. So it's my pleasure tonight to welcome Dr. Joanna Martin, who's leading on this exciting research. She's a senior research fellow and alumna of Cardiff, having been awarded her PhD here. Dr. Martin's work is focused on learning and understanding more about ADHD with the aim of improving its diagnosis, management and treatment. Joanna, I'm delighted you're here sharing your research with us tonight. We've already received questions in advance, but if you have any to ask, please enter them in the question and answer box at the bottom of your screen, and we'll answer as many as we can in the time that we've got available. But for now, I'm delighted to welcome Joanna. Thank you very much.
Hello, I'm just going to share my screen. Hi, thank you so much for joining us tonight. I'm excited to talk to you about my research on ADHD, which is funded by Health and Care Research Wales via Welsh Government. So just to give an overview of what I'm going to talk about tonight, I'm going to start with a bit of brief background on the epidemiology of what we know about ADHD, and then I'm going to focus on why ADHD might be missed in girls and young women, looking at a variety of different factors. Then I'm going to quickly talk about two different studies that are ongoing in my research group. We're looking at sex differences in diagnosis and clinical care in young people in Wales, and we're also interested in why diagnosis of ADHD is delayed or missed in some young people. And then I'll finish off with just an overall summary and conclusions. So ADHD is quite a common neurodevelopmental condition affecting about 1 in 20 children and young people globally. And it's characterized by symptoms that are to a severe degree and potentially developmentally inappropriate in 2 domains. Inattention, which is things like being easily distractible and forgetful, and hyperactivity and impulsivity, which is things like fidgeting or getting up out of your seat in situations where it's not appropriate or interrupting. And there are 3 presentations of ADHD. It's kind of an umbrella term for these 3 different presentations. There's the predominantly inattentive subtype, which has been previously known as attention deficit disorder, or ADD, the predominantly hyperactive impulsive subtype, and the combined subtype, which is characterized by difficulties in both domains. To get a diagnosis of ADHD, symptoms have to have been present in childhood. So although you can be diagnosed as an adult, the symptoms would have had to be present before the age of 12. And the symptoms need to be pervasive across settings. So what this means is, particularly in children, the symptoms need to be present both at home and at school, for example. And they also need to be associated with a significant impact on functioning in a variety of domains. So ADHD is much more likely to be diagnosed in boys compared to girls in childhood. But by the time we look at adult samples, actually, we don't see such a big male-female bias. So it's about 1 or 2 men for every woman who are diagnosed in adulthood. And what's going on is that there seems to be some kind of delay in getting the diagnosis in girls and women. So the median age at first diagnosis or recognition of ADHD is around sort of 11 years in childhood in boys and about 15 years kind of in adolescence in girls. And even when girls are diagnosed, they're over 3 times less likely to be prescribed stimulant medication for ADHD. Now, we know that medication can be highly effective for some people. It can improve a variety of outcomes and reduce a variety of risks. So we're seeing that there's this inequality in timely access and clinical care and treatment for girls with ADHD. And we need to find out what's going on and rectify the situation. So ADHD isn't just a childhood condition. About 2 out of every 3 children who have a diagnosis do continue to have difficulties, significant difficulties as adults, and it's associated with lifelong impacts on a variety of different domains. ADHD is associated with other neurodevelopmental conditions and learning difficulties, a variety of mental health conditions, and things like low educational attainment, unemployment, relationship difficulties, various physical health conditions, and it just has an impact on a variety of domains in life. We also know, just anecdotally, from women who've been diagnosed as adults, that they really wish that they'd been recognized sooner, that they'd been treated sooner, and that they really missed out on understanding themselves better because their ADHD hadn't been recognized. I recently published a review article of this topic, which you can freely download for about another month using the QR code that I provided. It's on the next few slides as well. And in this article, I really looked at what are the potential reasons for why this is happening? Why is ADHD being missed so often in girls and young women? Why is there this delay in diagnosis? And I focused on a variety of different factors and how they may intersect with sex to impact on the expression, recognition, and diagnosis of ADHD. So I'm going to go through these in a kind of summarized way. So first of all, thinking about biological factors, we know that ADHD is a highly heritable condition. It runs in families. Genetics are very important. So studies that have looked at males and females found that actually the heritability, so the genetic contribution to ADHD, is very similar in males and females. And there don't seem to be any sort of strong differences in the kinds of genetic factors that are associated with ADHD. In terms of things like puberty and hormones, there have actually been surprisingly few studies of these that were done in humans in relation to ADHD. So the evidence so far is a bit inconclusive, and we need more work in this area. In terms of social factors, we know that adults, like teachers and parents in children's lives, do have gendered expectations of children. And interesting studies have been conducted looking at providing parents and teachers with these descriptions or vignettes of children's behaviors and changing just the names and pronouns to either be male or female. And actually just that simple change can influence the decisions that teachers and parents would make in terms of how likely they are to recognize ADHD and what they would suggest maybe the support necessary would be. We also know that ADHD has these different subtypes, and actually the inattentive subtype might be more common in females. Inattentive symptoms perhaps are a little bit harder to notice by other people than hyperactive impulsive symptoms, which are a bit more disruptive to others, interrupting and getting out of your seat and that kind of thing. So if ADHD is more likely to be inattentive in females, then it might be harder to notice for that reason. And more recently, there's been emergent evidence in the neurodevelopmental world thinking about compensation and masking. So we know that a lot of young people will adjust their behavior to fit in amongst their peers and mask difficulties that they may be having so that other people don't notice them. And it's been found that autistic people do use such compensation strategies, and particularly that autistic females use these strategies. However, there's more limited research of this so far in ADHD, although emerging studies that are qualitative in nature, so asking people and interviewing them about their behaviors, suggest that masking may be a feature of relationships with neurotypical people for women with ADHD. But more research is really necessary on this topic. In terms of our diagnostic criteria, these are based on pretty much a male presentation, based on studies in the 1980s and the 1990s, which were very dominated by male individuals in the samples. So the criteria might not be perfectly suited to identifying a more gender diverse presentation of ADHD. And it could be that symptoms may present differently in females. It's been suggested that perhaps the symptoms are a bit more internal or a bit more social rather than kind of like task driven. So the criteria might need a little bit of revising at some point in the future. Another part of the criteria is this issue of pervasiveness across different settings. And it's been suggested that this may cause some difficulties with diagnosis for females because the parent-teacher agreement on whether a child does or does not have ADHD may be less likely in females in childhood. Studies have also started looking at this potential subtype of ADHD that could be onsetting later in life, so where the symptoms aren't so impactful in childhood, but do kind of cause more impact on someone's life later on. And it's been found that this later onset ADHD group is more likely to be females. And so this could be potentially explaining why there's this later diagnosis in some individuals. I also mentioned that people with ADHD are more likely to have mental health difficulties, and these kinds of mental health difficulties like anxiety and depression are more common in the general population in females. So there could be overshadowing from these other conditions that may be recognized and diagnosed first, but for some people, the underlying ADHD might be missed. And a final possibility is that maybe the diagnostic threshold is elevated in females. So maybe there's something more that needs to be going on in females for them to get to clinical attention and get diagnosed. And studies have looked at this in young people who have symptoms of ADHD and found that in this group, females are less likely to be diagnosed and given medication for ADHD compared to males with those levels of symptoms, unless they have these co-occurring disruptive or emotional difficulties on top of their ADHD. So as you can see, there's a variety of different things going on. There's kind of complex, multifaceted reasons for why ADHD might be missed. And it particularly seems to be the sociocultural factors and perhaps our diagnostic practices that are intersecting with sex to influence this. So now I'm going to move on to talking about the first study. And in this study, we were interested in looking at population healthcare records from people living in Wales across a 20-year time period and looking at sex difference in ADHD diagnosis and clinical care. So it's focusing on children and young adults. And we looked at a variety of different health factors, including things like age at diagnosis, various medications, and various diagnoses, neurodevelopmental and mental health diagnoses. And this is ongoing work that is currently under review, but you can access the preprint on the medRxiv server, and I've provided the QR code here if you're interested. We also wanted to assess the influence of various demographic factors, things like ethnicity, socioeconomic level, and contact with social services, to see if these were affecting what we saw in the data. And we also wanted to look at changes over time, so we looked at people's birth years. We used data from Wales, from the SAIL databank, which is a secure person-level anonymized healthcare data set using routinely collected primary and secondary care records. We focused on young people who were born between 1989 and 2013 across a 20-year time period right before COVID. Our diagnosis of ADHD came from primary care records using NHS read codes and secondary care records, which were based on diagnoses. We also looked at a variety of other healthcare records, and I've kind of listed a few things on the bottom right there, but I'll go through them on the next slides as well. And we also looked at demographic data. So in our sample, we ended up with over 13,000 males who had a diagnosis of ADHD and just over 3,000 females. This gave us a male to female ratio of 3.9 to 1, so about 4 males for every female in our sample. And on this graph, I've got different variables related to ages. So we've got on the axis over here, on the y-axis, we have age at first record. And on the x-axis here, we have a variety of different diagnoses and medications. So females are in orange and males are in purple. And what we see is that ADHD diagnosis is on average recorded later for the first time in females compared to males. And in this group of people with ADHD, many of them had a co-occurring diagnosis of autism or learning difficulties, and these diagnoses were also later in females compared to males. For people who had anxiety, there was no sex difference in terms of when they got this diagnosis, but for depression, females were younger at first depression diagnosis compared to males. And we also see no sex difference for other mental health conditions, which are listed here in the bottom in red. It's a group of different conditions that we had. When we looked at medications, we find that females were older on average when they first got medication for ADHD compared to males. And this was true of both stimulant medication as well as non-stimulant ADHD medication. For antidepressants, we found that females were younger than males at first prescription of antidepressant medication. And with regards to the ADHD medication, we also looked at whether there was a bigger gap in getting the diagnosis of ADHD and then getting the prescription for medication. But actually what we found that gap was about just over a year in males and females with no evidence of a sex difference. On this graph, we're now looking at binary variables. So whether people have got a condition or a particular prescription. And here we have the percentage and the variables on the x-axis. And again, females are in orange and males are in purple. And what we find is that nearly half of females were diagnosed with ADHD after the age of 12. And about a third of males were diagnosed with ADHD after the age of 12, so in adolescence, which is quite a big gap. When we look at people who are diagnosed as adults after the age of 18, it's about 17% of females and about 8% of males. So again, there's a difference here. In terms of whether someone received medication for ADHD or not, you can see that nearly 2/3 of the sample were getting medication for ADHD, but actually it was more likely to be the males than the females. Females were less likely to get medication. And this is particularly true of the stimulants, but not non-stimulants. We also looked at the subgroup of people who got given stimulants and non-stimulants at some point during the study period to see whether they've kind of changed medications, but we saw no sex difference in this group. Thinking about other mental health conditions, we find that females are more likely to have a diagnosis of co-occurring anxiety compared to males. A third of females with ADHD had co-occurring anxiety. And we also see a similar pattern for depression and a smaller difference here for other mental health conditions, which again are listed on the bottom of the slide. When we look at the people who had ADHD with anxiety, females are more likely for the anxiety to have been diagnosed before the ADHD compared to males. And same thing was true of depression, and same thing was true of other mental health conditions. So having a co-occurring condition was more common in females, and they were more likely to have that prior to ADHD in terms of recognition. Looking at antidepressants, we see that females are more likely to be prescribed any antidepressants than males. And for those people who do get prescribed antidepressants, females are more likely to have those prescribed prior to their ADHD diagnosis. And then finally, in the people who had antidepressants prior to ADHD diagnosis, females are less likely than males to continue to receive the antidepressants once the ADHD has been diagnosed, suggesting that there's been some change in their clinical care. The antidepressants are no longer considered necessary once the ADHD is recognized. As I mentioned, we were also interested in whether demographic factors influenced our results. I won't go into this in too much detail, but we didn't find evidence really that there was any kind of moderation effects from social services contact, various ethnicities, and deprivation level in our results. There was evidence of changes in terms of people's birth years, but we included the birth year as a covariate in our analysis, so we adjusted away these effects so they didn't influence our results. So to summarize this one study, we found that females are older at first reported diagnosis of ADHD in the Welsh healthcare records, which means that they're more likely to not be diagnosed in childhood, but to be diagnosed in adolescence or adulthood. They're also older at first recorded diagnosis of co-occurring other neurodevelopmental conditions like autism and learning difficulties. They're less likely to receive medication for ADHD, although we don't see a sort of evidence of a longer gap between diagnosis and medication prescription. In terms of co-occurring mental health diagnoses, we see that females are more likely to be diagnosed with something like anxiety, depression, or another mental health condition compared to males in general, but particularly also prior to their ADHD. So the timing of it is that they're more likely to get these conditions diagnosed first. They're also more likely to receive antidepressants at all, and they're younger at their first antidepressant prescription. And what's really interesting, I think, is that in those individuals who are getting antidepressants before they get ADHD diagnosed, females are less likely to continue to receive those antidepressants after diagnosis, which could suggest some evidence of some sort of misdiagnosis prior to ADHD diagnosis. And we found that the demographic factors we looked at did not intersect with sex. So moving on to the second study. This is work that is not currently published and is being led by my PhD student, Isabella Barclay. And here we're using data from the Millennium Cohort Study, which is a UK general population sample of young people. And we were interested in comparing individuals who'd had ADHD diagnosis, depending on when it was diagnosed, and also whether they had ADHD diagnosed or not. So we compared young people who had a diagnosis of ADHD by the age of 5 or 7, based on parent reports, compared to those who were diagnosed slightly later, so at age 11 or 14. And then we compared this group, who had any recognized ADHD, compared to individuals who had symptoms of ADHD based on parental report, but didn't have a recognized diagnosis by the age of 14. Then we looked at a subgroup who had those symptoms with additional functional impact. And we also looked at males and females separately where we had sufficient sample size. I've listed all the variables that Isabella looked at on the side here, but I'm going to talk about them on the next slides again. So first of all, in terms of our sample sizes, in this large group of young people, we had over 260 young people who had a diagnosis of ADHD by the age of 7, but a similar number by the age of 11 and 14. And this gives a male to female ratio of about 4 males for every female, so similar to what we see in that Welsh healthcare data. Then when we look at the unrecognized ADHD group, so individuals who had high levels of symptoms but no diagnosis recognized, we had over 1,000 young people. And in the subgroup who had additional impact at age 5 and 7, we had about 200 of those 1,000. And in this unrecognized group, we can see that actually the male to female ratio is a lot smaller. So we're finding that there are relatively more females who have this unrecognized ADHD in this sample. So first of all, we compared the individuals who got diagnosed earlier versus later. And on this slide, we can see that we've got the list of variables we're looking at here. And on the x-axis, we've got the strength of the effect size, the odds ratio. So if one of the effects crosses this line of odds ratio of 1, that means there's no significant difference between the groups. So what we're finding is that for a variety of variables, the earlier diagnosed group have more difficulties. So they have more emotional dysregulation difficulties than those who are diagnosed later. They have more problems with peer relationships, conduct difficulties, and emotional problems. They're less likely to have prosocial behaviors, and they have lower cognitive ability. When we compare the group of those who had any recognized ADHD compared to those who had unrecognized ADHD, so symptoms but no diagnosis, we see similar results. Again, we find that the individuals who have the diagnosis have more severe difficulties. They have more emotional dysregulation, more peer problems, conduct problems, and emotional problems, lower prosocial behaviors, and lower cognitive ability, as we saw before. But in addition to that, we also see that this group, the recognized ADHD group, are more likely to have a parent with a mental health problem like depression or anxiety. They're more likely to have a co-occurring autism diagnosis, and they have a little bit sort of lower levels of out-of-school physical activity as well. This is the same results, but just stratified by sex now. So we've got, in purple, we have males, and in orange, we have females. And by and large, the confidence intervals overlap, which means that we don't see different effects in males and females. The main difference is that for emotional dysregulation, we're finding that there's a difference in males, but not in females. So this means that males who have a diagnosis of ADHD that's recognized have more emotional dysregulation difficulties than males who have unrecognized ADHD. But in females, these groups do not differ. And in fact, these groups have high levels of emotional dysregulation, regardless of whether they have a diagnosis. And finally, this is the comparison with the group of individuals who have unrecognized ADHD with potential impact from their symptoms, comparing against those who have got a recognized diagnosis. And these groups are very similar. There's very few differences. The only difference is that the individuals who have a recognized ADHD diagnosis are more likely to also have co-occurring autism. But otherwise, these groups are very, very similar. So overall, we're finding that the male to female ratio is lower in the unrecognized group, suggesting there's relatively more females who have unrecognized ADHD. We also find that children are more likely to get a diagnosis of ADHD, and for this to be earlier on in life, if they have more difficulties, more mental health difficulties in general. They have lower cognitive ability, and they have fewer prosocial behaviors. And these are things like being kind of polite and easygoing. Additionally, we find that children with recognized ADHD are more likely to have co-occurring autism, a parent who has mental health difficulties, and lower out-of-school physical activity compared to those who have unrecognized ADHD. And additionally, when we look at the specific subgroup who are potentially the most likely to have unrecognized ADHD because they have this additional impact as well as symptoms, the only difference between them and the recognized group is this autism being more likely in the recognized group. When we look at sex differences, we find that emotional dysregulation problems differ in males between the recognized and unrecognized groups. There's no difference in females. There are similarly high levels of emotional dysregulation difficulties. So overall, we're finding that less severely impacted children are more likely to be missed, and this particularly seems to be affecting females. So just to give an overall summary, we're finding that, as is consistent with the literature, ADHD can be delayed or the diagnosis completely missed in females, and there's this inequality in access to clinical care and support as a consequence of that. There are complex and multifaceted reasons in a variety of different factors that may be influencing this. When we look at healthcare records in Wales, we're finding that females are more likely to be diagnosed not in childhood, but adolescence and adulthood. And we're finding evidence that there's this diagnostic overshadowing from mental health difficulties like anxiety and depression. We also find some evidence of potential misdiagnosis for a subgroup of people where there's discontinuation of antidepressants once the ADHD is recognized. And in terms of thinking about recognition of ADHD and what age that happens at, we're finding in the population data that children who are diagnosed later or have unrecognized ADHD but do have difficulties have fewer co-occurring difficulties. So the children who are diagnosed later have fewer co-occurring difficulties, less likely to have co-occurring autism, and have higher cognitive ability and prosocial ability. In general, we're finding that there is a subgroup of children who have symptoms and impact who are not getting diagnosed, who are potentially missed. And we're also finding that emotional dysregulation may be a particularly important aspect in female ADHD and in terms of recognizing ADHD. So we find that really, we know that our ADHD diagnostic criteria are based primarily on the male presentation, so we might need to consider additional symptoms more common in females. We also need to know more about whether the longer duration of untreated ADHD in females could be exacerbating potentially poor outcomes. So we need to understand factors and consequences that might be linked to late and delayed diagnosis. Unfortunately, we do find that there are very long ADHD assessment waiting lists currently in Wales, in the UK, and elsewhere in the world. And really, we need more resources and staff for earlier identification in young girls. So we need to improve this timely identification, partly through raising awareness for parents, teachers, and doctors on what to look out for in girls. And ideally, we need more sensitive assessment tools prior to referral as well. So I'd just like to thank my research team, collaborators, and our youth advisory group at the National Centre for Mental Health. And I'd just like to also acknowledge our funders, and particularly Healthcare and Research Wales, for funding this project. Thank you so much for listening, and thanks to all our study participants as well.
Brilliant. Thank you. That was a really, really good talk. And I was lucky enough a couple of weeks ago to spend a morning with the Wolfson Centre, and it really is inspirational. The work that you and your colleagues are doing over there. It's a fascinating topic. It really is. So we can open the question and answer session now. If you haven't already done so, please ask your questions within the Q&A box. I'm going to start by asking some of the questions that were submitted in advance. So Joanna, first off, do you think girls are taught to mask their symptoms more than boys?
I think that's a really interesting question. And I mean, I can only really give my opinion because we don't quite have enough research on this yet. I think this is an important thing to study in future. But it does seem to be the case in that there are these gendered expectations of children based on whether they are male or female. And it could be that girls are picking up on social cues that adults are presenting, that other girls around them are presenting with, and that they are kind of expected to act in a certain way, and that they do need to mask their symptoms. We're conducting interviews with young adults who have a diagnosis of ADHD, and particularly women, and they do talk about masking quite a lot. So it does seem to be something that's relevant. We also see this in autism as well in the literature, that it's very relevant to autistic women. So I think there's much more research that needs to be done on this, but I do think that there is some evidence of this emerging now.
Brilliant. Okay. And then a follow-up to that really is, can having a further medical condition mask ADHD symptoms?
Yeah, I think so. So in the Welsh healthcare data, when we look at anxiety and depression, of mental health conditions, it does seem to be that there's a greater likelihood of these conditions being recognized and diagnosed first before ADHD is recognized and diagnosed in women. So it could be that there's this complex clinical presentation. It's not necessarily clear what the most prominent difficulties are. Obviously, clinicians make a judgment on what's the most important thing to try to address and try to support people with. And this does change over time, but it does seem to be that it's more common for these other mental conditions to be diagnosed first, and then the ADHD perhaps to be picked up later, if at all.
Yeah, so it is quite a complicated picture then, I guess, isn't it? Some more questions coming in then. So I think you covered this quite early on in the talk. What's the role of genes in ADHD? And so is it a genetic condition? And do you know much about the genes and their penetrance, for instance?
Yeah. So I'm very interested in the genetics. Actually, I'm in the Center for Neuropsychiatric Genetics and Genomics at Cardiff University as well. So ADHD is highly heritable. So the heritability is kind of between 70 to 80%, which means that most of the kind of likelihood of getting ADHD is linked to genetics and biological factors. And it's a complex picture. It's not like there's one gene for ADHD. It's actually thousands or perhaps tens of thousands of genetic variants that individually contribute to ADHD. It's a complex condition. It's a brain-based biological condition. So there isn't sort of a particular gene that you can kind of identify. And it's sort of this collective contribution of a variety of different genetic factors, actually.
Okay. What's the current process to gain a diagnosis, and does this differ based on age and region?
I mean, I think there will be some regional variation across the UK and other countries, but the first step to the process is to speak to one's GP, either about yourself or your child, and then the referral kind of goes from there. As I mentioned, unfortunately, there is a waiting list, but yeah, you have to kind of go to secondary care services in order to get the diagnosis, because it is a complex process. Obviously, they need to get it right. They need to ask quite a kind of complicated history of what's been going on, particularly for an adult, in childhood, looking at school records, that kind of thing. So it is, it's a thorough process to do that.
And what do you think then, so we mentioned health services there. Are there things that local authorities can do that might make a difference to this? So is there any support that third sector or local authorities might be able to do to make a difference, do you think?
Yeah, so actually in Wales, we have a neurodivergent helpline that people can call, which is run by sort of local services. So that's sort of for people who know that they have a neurodevelopmental condition like ADHD or autism or something else, and they can ask for particular support that will be tailored to them by calling this helpline. But there are also many charities like Mind and the ADHD Foundation, neurodiversity charities who do offer additional support to people. So I guess there are these kind of charitable third sector organizations, and people can also access support through, if they're in higher education or in schools, there's people on hand to support young people with difficulties.
So perhaps local authorities could act as a link then between some of these organizations.
Yeah.
Okay. What have I got here? What do you think would help towards bridging the gap between diagnosis of ADHD in men versus women at an earlier stage of life?
I mean, I think raising awareness is really important. There's sort of very much a common prevalent stereotype of someone with ADHD being kind of an active boy running around and jumping on the furniture, but that's just like a tiny slice of the picture. It can really present in many different ways. Particularly the inattentive subtype is much harder to notice and can sometimes look like just a child who's daydreaming a lot, right? So I think awareness about kind of the full spectrum of what ADHD can look like and what it can look like in different people, what it can look like in adults, which is also different. Adults don't run around so much, but there might be this feeling of inner restlessness and that kind of thing. So I do think raising awareness. I think we also perhaps need more assessment tools that kind of can carefully pick up these more subtle features, perhaps self-reported as well. So, there's a few things that we can kind of work on to try to bridge that gap.
Okay, thank you. Do you think there's a hormonal link? And could a menopause hormone changes, it would probably be menarche, wouldn't it, be responsible for ADHD late diagnosis in women? So I guess it's the hormone around sort of puberty, maybe?
Yeah, so as I mentioned, the studies on this are actually very inconclusive at the moment, and they've tended to, like put boys and girls together and look at puberty together in boys and girls rather than looking separately and that kind of thing. So we do definitely need more data, and I'm aware of ongoing studies that are looking at these issues. But the preliminary things do suggest that if someone does have ADHD, so if a woman has ADHD, hormonal fluctuations through the cycle can kind of, the symptoms can wax and wane a little bit and the mood can wax and wane and that kind of thing. So there's likely to be some influences of hormones on attention, on mood, on all these things. But whether hormones can actually explain the sex difference we're seeing, that's not clear at all. I don't think we have conclusive evidence from human studies on that.
Okay. Comment here, wonderful talk. So there, and that's nice to hear. Are there any particular behaviours to watch for and or helpful in the early stage diagnostic tools or tests which parents or carers might deploy to help explore whether it's worth testing properly for ADHD? So again, this is probably a sort of home diagnosis to try and lead to a more formal diagnosis, maybe?
Yeah, I mean, I suppose because every child's very different, every child's difficulties will be unique. And the main thing really is, are there behaviors that are concerning? Is there something that sort of is impacting a child's ability to have and keep friends, to, enjoy things in life, to go out and do things, to have a good time in school? Is their mood low? If there's these things going on, then that can potentially suggest there's an underlying issue. In terms of the particular symptoms, there's kind of inattentive symptoms and hyperactive impulsive symptoms. You can kind of find lists of what those symptoms are online and have a look at those specific things. But I would say if someone's concerned about their child, really talking to the teacher, talking to the GP, those are kind of the first steps to sort of see, are these difficulties causing some difficulties in school, and what's going on, talking to the child as well.
Okay, good question here about the diagnostic criteria, I guess, and you mentioned that the necessity for presentation in childhood in order for a diagnosis to be made. But if a child has masked their symptoms, would this prevent a valid diagnosis later? And would this be treated in the same way if no sure diagnosis could be given?
Yeah, this is a really interesting question. And I think the kind of research is sort of grappling with this at the moment in terms of what to do with these later onset individuals who don't seem to have had difficulties in childhood. And I think it's sort of up to individual clinicians, and kind of that's why this evidence gathering is so important, to sort of speak to parents, to speak to, like look at sort of report cards. I know people sometimes have home videos and things that they use as evidence in terms of whether there were perhaps more subtle things going on that were causing difficulties, and like thinking about what could have been masking the difficulties going on. I think with regards to later diagnosis, you don't have to have had the full diagnostic criteria met retrospectively in childhood. There's just some level of symptoms need to have been present in childhood, I believe.
Okay, that's helpful. Thank you. What questions would you suggest asking to prevent overlooking a diagnosis in females? So, for instance, are there questions more about internal experience or masking that might help us make that diagnosis earlier?
I mean, I think this is a really key question. And actually, this is something that my research group is actively investigating. So I don't have a great answer yet, but, watch this space. Hopefully I'll be able to answer that question in a couple of years' time, I think.
No, that's a good answer, isn't it? The next question is about the impact of your research. So how quickly can your research affect change? How are you able to get your research to the clinicians who are diagnosing young people, especially girls, so that they can look beyond anxiety and depression? So it's dissemination of the message, isn't it, really, I guess?
Yeah, and our research group, the Wilson Center for Young People's Mental Health, we have very good links with clinicians. We have clinicians in our group. We regularly present our findings to a sort of diverse range of audiences. We have links with policy makers in Welsh government. So we kind of were set up to try to disseminate our research to the right people in the right way. So I think it's just kind of drawing on those networks and channels and making sure that our research is kind of loud and clear and openly available.
Yeah, I was particularly impressed with the Wolfson by the young persons advisory group. I think you've got the public and patient involvement really well sorted there, and a vibrant group of young people who are helping you with this.
Yeah, we're really lucky to have young people interested and involved in the research.
Yeah, that's good. Okay, aside from medication, what other treatments are there for ADHD, and what benefit does a diagnosis give?
Yeah, so I mean, there's a variety of things, and medication isn't necessarily the first port of call. So it kind of is done on an individual basis, depending on the young person's age. There might be kind of support with sort of like structural things like routines and parenting strategies to support a young person best in school. Someone might have a learning support assistant or a teaching assistant to get additional time, one-on-one input. So schools will do a lot, once that diagnosis is in place. For young people with ADHD who are struggling with additional difficulties like anxiety or mood, things like cognitive behavioral therapy can be supportive. So there's a range of things, and it really does depend on the specific person and the specific circumstances. And so it's something that needs to be kind of discussed with, doctors and educational professionals in that young person's life, really.
That's good advice. And then I guess, what is the relationship between ADHD and ASD? And my instinct was that it was a bit of a spectrum there, but many people seem to show signs of both of these disorders.
Yeah, so my PhD at Cardiff University was on this topic, actually. So it used to be that historically you couldn't diagnose the two, but actually that's changed quite a long time ago now. And ADHD and autism do co-occur quite often. They are linked. And actually what we found is that there's sort of, to some degree, a shared underlying genetic component to that link. So, you know, if you have a family member who has ADHD, your likelihood of having autism is increased and vice versa. So actually there's this kind of, you know, link in people having both, but also just it runs in families together to some degree.
Okay, and I think this might be the time for our last question, actually. I think we've only got a few minutes left. In your talk, you mentioned a difference between parent and teacher perception. Could you explain more on this? Is it parents who notice it or teachers first?
I mean, so this does vary from study to study, and it was, so the study in particular that I was talking about, the kind of vignettes and the descriptions, it was more about the sex difference. So basically parents were less likely and teachers were less likely to recognize the symptoms of ADHD if the description was females, and they were less likely to perhaps suggest things like medication or interventions. The differences between parents and teachers are a little bit harder to pin down. I mean, we do know that they provide different information because children have different needs in the home and school setting, and they will behave differently and perhaps mask differently and that kind of thing. So I think we do need more research on that side of things to really kind of understand what's going on, particularly with regards to sex differences in that context.
Yeah, perfect. Thank you. And then this is the last question. And it's one of, I guess for you now, for us to get an insight into your future. What are your research ambitions and what will you be investigating further with ADHD?
Yeah, thank you. Yeah, so I mean, I think this area is just so in need of so much further research. I'm really, you know, pleased that we've got this funding to be able to address some of these kind of key burning questions. And one of the things that our research group is working on at the moment is trying to develop kind of a new assessment tool that maybe captures some of these additional difficulties that aren't in our current diagnostic criteria, that aren't in our current ADHD screening questionnaires. So we're actually working with young adults, we're working with parents and teachers and education and healthcare professionals to try and develop this new assessment tool. So I think there's a lot of work that goes in behind the scenes to kind of make this robust and good and co-produce it with kind of key experts, and then to sort of test and validate that. So I kind of see myself doing that for a while, just making sure that we produce something that can actually be useful to the community and support people and have ADHD kind of recognized sooner, really.
Brilliant. I mean, Joanna, thank you so much for joining us today and talking about your research activities and your journey through Cardiff University. It's been really interesting, but we are out of time today. I would like to thank all of our webinar audience for being with us, and I hope that you found it interesting and got something from it. If we didn't get a chance to answer your question, we'll follow it up with you directly. So I think the team will be able to get something back to you after this event. So you will receive an email in the next few days. It'll be a copy of the recording and links to the register for future events. To plug the next event in the series, it's going to be understanding how a high-fat diet increases the risk of pancreatic cancer. And that's taking place on Thursday, the 21st of March at 5:15 in the evening. We very much hope you'll be able to join us for that. There will be a different chair probably, but I think it's certainly set up to be another fabulous talk. If anyone watching would like to get involved with Cardiff University, volunteering time to help our students or helping us to fundraise for our research, please follow the link in the comments box on the screen now. And from myself, and on behalf of our speakers this evening, or speaker, Joanna, diolch yn fawr, thank you and goodbye, and enjoy the rest of your evening.